Oh, right. Hi, folks. I am not we're here to represent the OLD. I'm just stealing 45 seconds to remind you that the polls are open for the CMA election, and someone very important to me is running. So I would ask you, you should have received an email on Thursday the 15th from the CMA, and the subject line opens with the word voting. And I'm reminding you not just to be a pest, but because some people have not been able to find the email or have had trouble getting it to work. So they've worked out the kinks. If you haven't voted, please do so. If you're having any trouble, email me, and I'd be very glad to help you vote. And if you'd be able to forward an email to your friends and colleagues suggesting that they vote, I'd be very appreciative of that as well. Thank you very much. Now to Shawn.
All right, good morning, everyone, and thanks for coming. So those of you who I haven't had the chance to say hi to, my name is Shawn Chhabra, and I'm one of the PGY3 emergency medicine residents here, and I'm going to be presenting rounds on the new and old of ED capnography. My supervisor for these rounds are Dr. Warren Chung, and some of you may remember that in 2013 he gave rounds on capnography. So these rounds are meant to provide updates, settle some controversies, and maybe even towards the end start some other ones. So the rounds will be broken down into three main topics. We'll just do a very brief review on capnography, and then we'll get into areas where the literature is more established, and specifically in procedural sedation and cardiac arrest. And then we'll end off in areas where the literature is more emerging and it's more controversial, and that includes areas of using capnography in the rapid sequence intubation and in the refining the diagnosis of PE. So, just to begin, we'll talk about the concept behind capnography, and specifically we'll talk about what types of capnography we have available for us to use here in Ottawa. Just a high-level overview. Air goes in through the lungs, oxygen goes into the bloodstream, and that's the concept we all know of oxygenation, that we're able to measure with a pulse oximeter, and we get an oxygen saturation. This oxygen then goes into the muscles where an aerobic process happens, and a byproduct of that is CO2. The CO2 then goes back into the bloodstream that we're able to breathe off through ventilation, and we're able to measure that through capnometry, and that will be an end-tidal CO2. The types that we have are two main types. So there's a qualitative type, and what happens here is that it's a color change in response to the presence of CO2. And we use this for the established indication of confirming tube position. And if you're interested in learning a little bit more about this, I'd encourage you to check out Dr. Chung's rounds. We're going to be specifically focusing more on the quantitative types, where you actually get a number to it. And if there is a number and a wave, we refer to that as capnography. And if we have just the number itself, we refer to that as capnometry. But we're just going to be using these words interchangeably here. And looking at the wave itself, it's broken into four main parts. So phase one actually starts right at the beginning part of expiration down there, where you still have no CO2 measured. So what's happening is that you're having emptying of your anatomic dead space where there's no CO2 exchange. And then you have a rapid rise in CO2 as you start to get air from your lung parenchyma that then begins to plateau at the level of the alveolus to a maximum number, which we call our end-tidal CO2, which for the rest of the rounds you'll be seeing ETCO2 as the acronym for it. And just as a representative, our normal number will be somewhere between 35 and 45. So we kind of pick 40 as a normal end-tidal CO2. As phase 3 ends and we reach our end-tidal CO2, we begin inhalation, and we have a rapid decline in the CO2 that then leads into our next wave. So in terms of what we have available to us here, there's two main types. The first one is called mainstream capnography, and what it is that you have a cannula that you're able to insert into your line in an intubated patient, and it's direct sampling, continuous sampling of CO2 that's being exhaled by the patient. The second type, called side stream, is what many of us are very familiar with. And what happens is you have a nasal cannula where you're able to deliver oxygen to the patient, and then it's sampling intermittently the CO2 for the patient, and it samples it by what's exhaled through the nose and the mouthpiece. And that area that says unijunction in the picture is an infrared spectrometer that's able to measure the wavelength of CO2. It's a specific wavelength. And then that gets displayed onto the screen as a number. So these are the two types that we have available for us here. And that's it. That's the brief review that we're going to go with. We're going to start this section by talking about areas where we have the most amount of literature, and that includes procedural sedation and cardiac arrest. So for procedural sedation, can I just get a hands for the people in the room that are using capnography in their procedural sedations right now? Okay, so a fair number. And when Dr. Chung gave his rounds, he presented the controversies of using of capnography. And this is likely reflected by what we see in the room here and what our RTs tell us about the civic and the general, that it's about 50-50 for us using capnography and not using capnography. The main controversies are that there's a series of pros and cons. And when people talk about the advantages of using capnography, they mainly refer to this paper in 2010 from the Annals of Emergency Medicine by the Deitch group. And it's titled, "Does End-tidal CO2 Monitoring During ED Procedural Sedation Decrease the Incidence of Hypoxic Events?" So it's a systematic review, a prospective RCT, a randomized control trial. So it's a prospective RCT that was done at a large teaching hospital and included a total of 132 patients. And what they were looking at is, does waveform capnography, compared to what we have as our standard monitors, which includes oxygen saturation, blood pressure monitoring, and traditional cardiac monitors, how do they compare to one another? And their objectives were looking at respiratory interventions, which they included to have verbal stimulation, physical stimulation, bag mask ventilation, or endotracheal intubation. Hypoxia, which they defined as less than 93% for 15 seconds. And respiratory depression. Now, these are actually end-tidal CO2 markers. So an end-tidal CO2 greater than 50, a change in your end-tidal CO2 greater than 10, and apnea for 15 seconds. And apnea is measured by having a flat line on your capnogram for 15 seconds or more. So what's important to recognize here is that regardless of which group the patients got randomized into, they all had capnography placed. And if you were in the capnography group, the treating physician had that the capnography data available to them. If you were in the control group or the blinded capnography group, then the end-tidal CO2 numbers were not available to the treating physician. And what did they find? They found that there was a similar number of respiratory depression events, regardless of what group you're in. But their findings can essentially be summarized by this one table, that there was a statistical increase in hypoxia in the blinded capnography group. So 42% of patients in the blinded capnography group experienced hypoxia, and only 25% in the capnography group experienced hypoxia. So this is a relative change of about 40%, and that number is going to come up a little bit later, that 40%. So their conclusions from this was that capnography reduced hypoxia, and they suggested that the reason it reduced hypoxia was because it provided an advanced warning for the hypoxic event to happen. And thus, by using capnography, emergency physicians improved patient safety. And this became quite a practice. It was practice forming in the sense where people looked at this and said, this is a measure, I'm doing this procedure quite routinely. This is a way that I can improve the safety of my procedure itself. It's important to understand the limitations that were in this paper. There's quite a range in the spectrum of their respiratory interventions. So I think we can all agree that yelling or shaking a patient is different than intubating that patient, but they actually didn't comment on what type of intervention that patient then ended up having. So 25% of patients had a respiratory intervention, but we're not sure what the intervention was that that patient then ended up having. If you looked at the group of people that were using capnography, they had an increased number of interventions, even if they were not experiencing hypoxia. So we had an increased number of respiratory interventions with or without hypoxia. And importantly, there were no patient-centered outcomes here. So does having an O2 saturation of 92%, 91% have any sort of physiologic impact? That wasn't necessarily commented on. And I think it's important to understand these limitations. But this really formed the basis of Dr. Bancourt? Yeah, no problem. Yeah, so in all adult populations, we administer supplemental oxygen, and that's what they did in this group here. They did, yeah. So that wasn't one of the respiratory interventions itself. So these are kind of the limitations here, and this kind of formed the basis of the PRO group. There's been a series of studies that were before and some afterwards, but the one that I would like to point out to you guys is a 2017 Cochrane review that looked at this question of capnography versus standard monitoring for emergency department procedural sedation. And some of you may recognize some of the names that are associated with this Cochrane review. And their objectives were they looked at the literature and were able to distill it down into 3 RCTs, which totaled over 1,200 patients. And they were identifying the topic of wave capnography versus standard monitoring, the same sort of standard monitoring that we would have available to us. And the outcomes that they were looking for were desaturation, hypotension, emesis or aspiration, and any airway interventions. Now, these airway interventions did not include verbal stimulation or physical stimulation. So it was more bag mask ventilation and endotracheal intubation and repositioning. Those are the 3 things that they were looking at. So what did they find in there? So the Wall group found that there was no difference in desaturation. There was no difference in hypotension. And there was a single episode in emesis in the control group, the blinded capnography group. So no meaningful differences in things that we would be looking for as physicians. But what they did find was that there was an increased rate of airway interventions in adults. So much to say that they commented that if we're doing respiratory interventions for something that is not clinically meaningful, we could potentially be harming the patient. And they went on to say that there's a number needed to treat to harm of 14. And if we look specifically just at the adult population, because they looked at pediatric and adults, if we look specifically just at the adult population, it's actually a number needed to treat to harm of 12. So from this, their conclusion was the addition of capnography does not reduce the rates of clinically significant adverse events, which is the message that I think that we should be taking from here. There's no change in our clinically significant adverse events. Okay, so we looked at the clinical impact, but what about an economic impact? So this year there was an interesting paper released that looked at the use of capnography, but doing a cost-effectiveness analysis of it. So they wanted to see what the cost-effectiveness was if we routinely used capnography in procedural sedation. So they did an estimate to see what would be the cost per prevented catastrophic event. And they're catastrophic events that they defined as hypoxic brain injury or death. And I may be grilled a little bit on this paper a little bit afterwards, but you have to understand some assumptions with this paper that are really important. So they searched all of emergency medicine literature. So they looked at the RCTs, observational trials, and case reports. And they were actually not able to find a single catastrophic event. So no hypoxic brain injury and no death. So they then expanded their search. They went to the anesthesia literature, inpatient and outpatient. So we're talking endoscopy suites, we're talking dental procedures. And they said that considering we can't find anything in the emerge literature, surely it's not going to be any higher than what we can find in the plethora of anesthesia literature. And so what they did is they found that event rate in anesthesia literature, and it was a 5-year estimated event rate of about 15 events. So 15 events happening over a 5-year period. And you're probably wondering why we're looking at like a 5-year period. It's going to become apparent in just a second here. So 15 events over a 5-year period. And their second assumption was taken from the Deitch paper, where they said we can reduce our event rates by 40%. Now, if you remember, the Deitch paper was looking at specifically hypoxia. So they said to be as conservative as possible, we will assume that all hypoxic events lead to hypoxic brain injury, which we know is not true. But this is actually an accepted practice in economic modeling where you want to try and be as safe or as conservative as possible. So this is okay to do. Well, it's an accepted way to go about it. So they said we have our 15 events per year. We can potentially reduce it by 40%. So that will lead to approximately 9 events over a 5-year period if capnography is continually used. And then they associated a cost with that. And what their findings were that if we were to routinely be using capnography, it would cost approximately $3 million per catastrophic event, with the caveat that there are no catastrophic events that have been reported in the emergency medicine literature. And if we were to have that, the way that a cost-effectiveness analysis gets presented is a quality-adjusted life year, a QALY. and it would be $114,000 per quality. Now, in economic literature, the maximum accepted number is about $50,000 for any sort of funded intervention. So this is double the maximum of what economics thinks is an acceptable number. So their finding from this went on to say that if we were to be routinely using capnography, it's a very costly strategy given the exceedingly low event rates. So what do we take from this section of procedural sedation? That it does not reduce any sort of clinically significant adverse events, and importantly, it may actually increase the number of airway interventions that we're providing. And as Cochrane will say, that's a number needed to treat to harm of 12 in our adult population. And it's a high cost for a routine procedure with a low event rate. As such, I give it a thumbs down that we should not be using this as part of our standard practice. Okay, so we started off by talking about how there's a section where there's the evidence that doesn't support its use. What about the other sides, when cardiac arrest? And can I just get a hands up to see who's routinely using end-tidal CO2 in their cardiac arrest patients? So a huge number. Great. We're going to focus on 3 areas of cardiac arrest. We're going to talk about CPR quality, we're going to talk about prognostication, and we're going to talk about using end-tidal as a marker of ROSC itself. So with end-tidal and CPR quality, the Kalenda group in the late 70s were the first people to report the association with CO2 and CPR. And they noticed in 3 cardiac arrest patients that they were studying that as a compressor got tired, their CO2 the patient's CO2 began to decline. And this kind of formed a little bit of the basis of routinely switching out our compressors. And they also noticed that as ROSC was achieved, there was a significant increase in what the CO2 value was. There was about 20 years worth of research in between, where there was numerous animal studies and human studies to kind of look at this association between CO2 and CPR. And there was a seminal trial published in the New England Journal of Medicine in the late 90s that looked at the value of CO2. So a CO2 less than 10 after 20 minutes of CPR was a strong predictor of death. In fact, they said that there was a sensitivity, specificity, and a negative predictive value of 100%. So the AHA in 2010 went and summarized the literature that they had available to them and made this statement in our ACLS guidelines that said an end-tidal less than 10 is equal to a poor cardiac output, and as such, we should be trying to improve our chest compressions. They went on to say that we should actually be trying to titrate our CPR compressions to an end-tidal CO2 of 20. In 2015, they backtracked on that a bit because they realized there was insufficient evidence to actually suggest titrating a CO2 or CPR to an actual CO2 level. So we have no specific goal that we should be looking at. But what they did say is that capnography should be used to monitor and optimize CPR quality. And I think that that's the message that I'm trying to display here, is that there's no evidence to kind of give us a certain number to titrate to. If you can compress and keep that patient above 10, you're probably likely doing them a service. But if you start to see a waveform that looks like this, you're hitting a number, then it starts to drift off, this might be a time where you're considering switching out that compressor even before your 2-minute time to switch out. The Levine paper brought up an interesting question. So what does that end-tidal number really mean? Like, can we use it for prognostication? And there have been a few actually recent papers that try and summarize the literature. I think the best structured review was actually just published this month in Resuscitation by the PEVA group. And it's looking at end-tidal CO2 to guide management of cardiac arrest. And it was a systematic review. So they looked at 17, they included 17 observational trials, with 14 of them being prognostic, for a total of over 6,000 patients. And out of those 17, there were 5 studies where there was a sufficient amount of end-tidal CO2 data points to then do a meta-analysis on it. Now, I should say that we're talking about observational trials, so by nature, it's going to be low-quality evidence that we're starting with. But I don't want you to leave by saying that this is low quality and therefore not important. I think it's low quality and important information. They wanted to look at, does any level of CO2 during CPR correlate with ROSC or survival? And the outcomes they were looking at, ROSC, of course, 24-hour survival, survival to discharge, and then any long-term survival, of which they were not able to find any evidence on and not be able to comment on. So their findings were that an end-tidal CO2 greater than or equal to 10 at various time points was consistently considerably related to ROSC. There was only one paper that commented on survival to discharge. It was the Aaron's trial, and they looked at different time points. So they looked at an initial end-tidal CO2 and a 20-minute end-tidal CO2, and they looked at different CO2 values, so a greater than or less than to 10 and a greater than or less than to 20. Now what I'm presenting on this table are odds ratios here. So what you can see is that regardless if you're looking at your initial or if you're looking at your 20-minute end-tidal CO2, as you move to a higher value, so from 10 to 20, your odds of survival increase as well. So it was a well-structured review. Now they did have a challenge in the heterogeneous definition of what an initial end-tidal CO2 is. So in certain papers, does that mean initial as first arrival into the emergency department, immediately after intubation, and if that intubation doesn't happen right away, does your initial then become a random time point? So well-structured review, but challenging information to work with. Their conclusions from this, however, was that various end-tidal CO2s, so whether you're looking at it immediately after intubation or at a 20-minute time point, are consistently associated with an increased chance of ROSC and survival to admission. And that more is better. So if you have a value of 20, it's better than 10, 40 is better than 20. With respect to our initial levels, an initial level, I keep saying above 10, an initial level less than 10 doesn't predict futility. So I'm not trying to say that if you get that patient, you put an end-tidal, and it's 8, that we call this as a futile resuscitation. There was a study that if you wanted, we could chat about afterwards that looked at, and there were survivors with initial levels less than 10. However, if you're looking at the 20-minute point, you've been having ongoing CPR and you see an end-tidal CO2, that does predict futility. There's a 0.5% likelihood that that patient, after 20 minutes, is going to achieve ROSC, and it's likely good in your armamentarium, along with ultrasound, to call this as a code. Okay, so we talked about CPR quality, we talked about prognostication. What about as a marker of ROSC itself? So AHA and ACLS will tell us that we should be using capnography as a way to improve our CPR, guide resuscitation, but then also as an indicator of ROSC itself. And I think this is actually an important topic, because if we're able to have a bedside tool that's able to detect ROSC, then could we functionally be just getting rid of the pulse check as a whole? There's been a lot of, again, low-quality evidence, because they're observational trials. There's no RCTs on this. One that I would like to present to you is by TAT in 2016. And they looked at an abrupt and sustained rise in CO2 as an indicator of ROSC in out-of-hospital cardiac arrest patients. So it was a cross-sectional study. There was 2 emerges in Hong Kong, and it was a total of 178 patients. And they wanted to see how accurate is that abrupt and sustained rise as a marker of ROSC itself. The outcomes they were looking at were an end-tidal CO2 rise greater than 10, an end-tidal CO2 rise that was greater than 20, or any combination of that to a level that was greater than 40. They were able to achieve ROSC in about a third of their patients, and their findings were that overall there was low sensitivity. So low sensitivity means just because it's not there just because you can't have that value doesn't mean that you can immediately say that ROSC hasn't been achieved. But there's a high specificity. And as you increase in your values, so as you go from greater than 10 to greater than 20 to a value that's over the 40, the specificity increases at the expense of sensitivity, to the point where if you have a rise over 20 and a value over 40, then your specificity for that is 99%. So overall, low sensitivity, high specificity. So this is definitely not a replacement for our pulse checks, but it could be used as an indicator of ROSC itself. And where does this become important is, I would say in our PEA patients where we're not always able to feel the pulse, we can be using this as a marker of likely achieving ROSC. And as the Europeans will say, and many of us have talked about the use of epinephrine, if you see this marker, I'm not telling you to stop your CPR and do a pulse check immediately, but it may give you the thought of not administering that epinephrine to that patient who you likely have achieved ROSC on until you wait till your pulse check. So conclusions from this overall section. So with respect to CPR quality, I think that it's good to be using to guide our CPR quality. And if we start to see that declining waveform, to switch that compressor before 2 minutes. They're likely tiring. We don't know when the best time to check is. Is it initial? Is it at some point? Is it 20 minutes on? But if that patient does have an end-tidal CO2 greater than 10 to 20, it is a predictor of ROSC itself. And the higher the number, the better it is. Our initial end-tidal does not predict futility, but if you've been having ongoing CPR for 20 minutes and they have a value less than 10, then that patient has a 0.5% chance of achieving ROSC. Now with ROSC itself, highly specific, not sensitive. Therefore, do not replace your pulse checks by just looking at the end-tidal CO2. But if you are noticing that you have an abrupt and sustained rise, then you likely have achieved ROSC in that patient. Overall, thumbs up. This should be part of our standard practice. I'm glad to see that nearly everybody put up their hand. Okay. So the next section, so hopefully we've settled a little bit of the controversies around the first two. The next section, the last one that we're going to talk about, is areas where there isn't a wealth of data, but it's quite interesting and maybe controversial. And that's going to be using capnography in the rapid sequence intubation and pulmonary embolism. And for rapid sequence intubation, we're going to be using it as the waveform as a marker of paralysis. And is anybody doing this at this point? Okay. Nobody put up their hand. So, so this is a common procedure. It's a critical procedure, but we don't actually have the best data as to what an objective means of paralysis is. So we administer succinylcholine, we administer rocuronium. Some of us wait an arbitrary 45 to 60 seconds, we flick the eyebrows, we move their jaw. We don't have sort of objective means to say, is this patient paralyzed? So the Shawn group out of New York wanted to see if we could use wave capnography as a more objective means of paralysis rather than physician gestalt. So they used the concept behind what we talked about in procedural sedation. So we know that capnography is a sensitive marker for apnea. Can we use that as a marker of paralysis itself? So it's a pilot study. There was 100 patients that were enrolled, 50 patients into each arm, and all of them had a nasal cannula capnography administered to them. And they wanted to compare the waveform capnography versus physician gestalt in detecting paralysis for all their patients undergoing RSI. This doesn't include cardiac arrest patients, traumatic arrest patients, or anybody that required an awake intubation. And their outcomes that they were looking for was failure to detect optimal intubating conditions, which is going to be referred to as FTD on the next slide. And the way that they defined failure to detect optimal intubating conditions was capnographic data. So does that patient have apnea measured by a flat line for greater than 10 seconds? Can an independent observer say that that patient's been apneic for greater than 10 seconds? And one other thing. Oh, the need to redose neuromuscular blockade. So the combination of any of those three were what defined the failure to detect. They also looked at time to intubation. They looked at first pass success and first pass success with hypoxia, and also the lowest overall oxygen saturation. So what they found was that there was substantially more failures in detecting optimal intubating conditions. So 32% of failures in the Gestalt group and 6% of failures in the capnography group for an absolute difference of 26%, which would give us an NNT of around 4. They found that there was an increased time to intubation, 136, so an absolute difference of 20 seconds, longer in the Gestalt group. And if the physician was to fail to detect optimal intubating conditions, so fail to detect apnea, their time would actually increase by an average of 35 seconds. They also noticed trends that there was higher rates of first-pass success in the capnography group and lower rates of first-pass success with hypoxia, and an overall increased oxygen saturation. Now, of course, you have to take this data with a grain of salt. We're talking about 50 patients in each arm. But these are the trends that they were starting to display. So they concluded that that capnography may actually be a useful objective means to determine paralysis. and it may reduce the premature intubation or the delayed intubation or the need to redose neuromuscular blockade. And why I think this can be important is that it's a critical procedure, but we're often doing it in critically ill patients. And that difference of 20 seconds or 35 seconds, or having a way that we're all on board, the physician and the RT and people around us, that patient is ready for intubation, is something that would advance our practice. There are definite limitations. So, of course, it's a pilot study. They don't have high numbers. They're not powered. I have a challenge of understanding their definition a bit on the failure to detect optimal intubating conditions. So we're using a capnographic definition despite it not being validated. So they're trying to study it, but they're using it as their standard as well. So it was very challenging to wrap my head around that. And did they even analyze, they commented they weren't able to analyze on if they achieved neuromuscular blockade in the same sort of rate between the two groups. But overall, like what I would say about this, it's a preliminary study, but definitely has some promising results, and it may actually be a more objective way to assess paralysis in our patients. This can easily be integrated into our preparation, so I give this a thumbs up for the effort that they had and for the potential that it brings for us. Okay, last one, and I don't think it would be a true grand rounds without talking about sepsis or PE, so I'll throw this in here. To understand how capnography will work in the PE patient, we have to briefly talk about how PE would affect CO2. So in our normal lung ventilation, you have an equilibrium that gets formed between your arterial CO2 and your alveolar CO2, and that's what gets breathed out at a rate of 40 milligrams mercury. When you have a PE, we have what's called dead space ventilation. So let's just take our two alveoli here. So we have an area where there's normal perfusion, and then we have an area where there's impaired perfusion because of a clot. So you don't have that equilibrium that forms between your artery and your alveolus. And as such, you're getting a mixing of different numbers. So here we have our one that's perfused, that we're getting a reading of 40, and the one that's not perfused, that we're getting a reading of 0, to make an end-tidal CO2 reading of 20. And you'll see that there is a difference between the two of them. This can also be measured as an alveolar dead space fraction. So this concept is just essentially looking at the difference between your alveolar measured on your blood gas, and your arterial, measured on your blood gas, and your end-tidal CO2 measured on your capnometer. And this concept I'm going to talk about a little bit later on. You'll see the relevance of it. So in the diagnosis of PE, I suspect we're all following a similar algorithm where we start with a pre-test probability. So we're not going to be focusing on the high-risk patient where we would be sending this patient for a CT. We're also not going to be focusing on the ultra-low-risk patient, the patient that you're able to apply a PERC rule and rule this patient out clinically that they have a PE. So it's in this other subset that I think that we have a challenge with, where they're low risk, but we would need to do some advanced testing, whether it's D-dimer testing or CT testing on them. So we were looking to see is there a role of capnography in the diagnosis of a PE patient? And there was a meta-analysis that tried to address this question of can it be used as a diagnostic tool. And they looked at, instead of doing a dimer, could we be using end-tidal CO2? And the review was able to find a total of 14 trials, 2,000 patients in total. There was a 20% overall prevalence of PE, which I would say is higher than our average of somewhere quoted around 13 to 15%. The studies did include 4 studies by Dr. Klein and 1 study out of Ottawa with Dr. Wells. And overall, they were looking at the pooled accuracy of capnography in diagnosing PE. There were some challenges in this, is that research, the literature has different ways of describing the capnographic values. So as we talked about, are you using an end-tidal reading? Are you using an alveolar dead space fraction? So there are heterogeneous definitions. But what they were able to find is that overall, using end-tidal CO2, we have a sensitivity of 80% and a specificity of 49-50%. Now compare this to the dimer, highly sensitive, nearing 100%. Specificity is kind of around 45%. So we use the dimer because it is highly sensitive. And if it's negative, we're able to rule it out. This test is less sensitive than the dimer, so likely of no use to us because the dimer would allow us to rule out patients, and this wouldn't be able to do it with the same sort of certainty. But if we look into the studies that were in that review, there was one that I found was particularly interesting. It was by Yoon, and it was an observational study again of 112 consecutive patients. And they were looking at the subset of patients who were low risk but had a positive D-dimer, who I think we all kind of struggle with a little bit. We all come across this patient. Low risk with a positive D-dimer. Is there a role for end-tidal CO2 in that patient? And they were using the alveolar dead space fraction, so a measure of difference between the arterial CO2 and your end-tidal CO2. And they would say that a normal is less than 0.2. Now, functionally, what does that mean? That means that if we take our normal to be an end-tidal CO2 of 40, it would actually be an end-tidal CO2 reading of 32 or less. Okay? So a normal would be less than 0.2. And what they found was that if a patient was D-dimer positive and had an abnormal dead space, they had a sensitivity that matched the D-dimer alone, but increased the specificity to 78%. So now a test is more specific. We're able to start ruling in the diagnosis. Ruling in the diagnosis. So we're moving this more from a screening test to potentially a diagnostic test. But I know you're all kind of looking at this like 78%, still going to get the CT on the patient. What they did look is at the normal, people with normal alveolar dead space fractions. And it's small numbers, but if you had a normal alveolar dead space and a positive D-dimer, none of these patients went on to have a PE. So they found now we're looking at sensitivity here, because we're ruling out the diagnosis, a sensitivity of 100%. So this comes with methodologic flaws. These are 9 patients, so low numbers. The alveolar dead space fraction, you have to look at, is this a validated means? How accurate is it to compare it to your arterial CO2? And did they comment on the types of PEs that the patient have? No, they don't. So it's not meant, but I think this is quite interesting, because this would, if replicated and validated, would be a way to actually obviate getting the need of a CT. You do a D-dimer, it comes positive. You do the end-tidal CO2 with an alveolar dead space fraction. If it's normal, we may be able to rule out PEs in patients. So what do I want you to take from this? Is that we know that our algorithmic approach is there to help this challenging diagnosis be a little bit more simple, but it comes with its own difficulty. And we need to continually consider is our algorithm appropriate, and is our imaging selection appropriate? It is definitely not a replacement for the D-dimer. And overall, it's something that's interesting, but more research needs to be had. Will it move from a screening to diagnostic test? Likely not. Is there a role of the dimer? Is there a role of end-tidal CO2 in the positive D-dimer patient? That would be interesting. And how does this all fit in with what our current algorithm is with an age-adjusted D-dimer? That's not something that was studied at this time. So overall, I would say that this one is a work in progress. Dr. Vancourt, you had a question? Mm-hmm.
Almost like a training the TNI to try to help us determine without
So Dr. Vancourt is bringing up an interesting point of, if this is something that can be replicated, then would this be advantage in the patients where we're looking at large clots, proximal clots, versus distal clots that may or may not need to be treated? And if they have a positive dimer, but it's not affecting their CO2, then could that be a way to kind of think about not treating something that may be a distal clot and maybe obviate the need for a CT? I think that's a very interesting thought. So overall, let's just run through a quick summary here. So for procedural sedation, I think that it does not decrease the rates of significant adverse events, and it actually may increase airway interventions and come with an economic cost. So overall, this should not be part of our standard of care. I give it a thumbs down. For quality and cardiac arrest, I think that we should be using it to guide quality. We don't have a definite number that we should be titrating to. If you can keep it above 10, that's great. But it can be used as a marker of a fatiguing compressor. For ROSC, a value that's greater than 10 is likely a predictor of ROSC. And a value less than 10 after 20 minutes is a predictor of futility that I think that we can use as in part of our armamentarium of calling a code. It does not replace our pulse checks, but if present, abrupt and sustained rise, that this could be a marker of ROSC itself. Overall, I give it a thumbs up. In using it for the rapid sequence intubation, so this may be an objective way to assess paralysis, and it's easily integrated into our preparation. I really like what this study was doing here, using it in a way that we know is established and trying to do it for something that we do in a common but still critical procedure. And I'm interested to see where this goes in terms of a potential RCT. In terms of refining the diagnosis of PE, it definitely does not replace the need for a D-dimer, but it may have a developing role in the low-risk patient that does have a D-dimer, the patient that tends to provide a little more of a diagnostic challenge for us. So overall, a work in progress. So thanks, everyone, for your attention. I would like to thank Dr. Chung for his supervising role and providing excellent feedback on this rounds. I'd like to thank the RT group for providing information of what we have available to us, walking me through Untitled Capnography, and then giving a sense of who's using it, who's not using it. And most importantly, I'd like to thank my wife, Jillian, and baby Rohan, who have been invaluable supports and have had to have an absent father and husband while I've been preparing for these grand rounds. So thank you, everyone. I'd be happy to take any questions.